My name is Brian Meshkin. I am married to my best friend for over 17 years. I have three amazing kids. We live in Orange County, South Orange County, in Southern California. I'm originally from Howard County, Maryland. I have spent my entire career looking at ways to be able to improve the healthcare system by using the leading edge technologies to improve the way decisions are made. I started my journey, if you will, in thinking that I could make a difference in a way. I consider myself a social entrepreneur, someone who likes to change things in such a way that makes a positive difference in the lives of people. I have done that as an activist, as a volunteer in the community, as an elected official, as well as in my career as a business person. I think anybody who thinks they can change the world in a positive way probably has to have some Pollyanna notion that they can make a difference. And it's hard to do. And as I've grown, I've learned that there are ways to do that in effective ways, and I've also learned that there are a lot of forces that will work against change. I developed this notion that someone like me, who isn't particularly special, could really make a difference at a young age. When I was 13 years old, a good friend of mine was riding his bicycle in front of my home when he was hit by a car, and he died. And I was one of the first people on the scene. And after going through that experience, it gave me the opportunity to get over that invincibility complex that I think a lot of young people feel, that it can't happen to them, that they're definitely going to live tomorrow or live for the next 15 or 20 years. And in dealing with that grief, in dealing with that loss, myself, along with a lot of our classmates, felt that we wanted to do something to give meaning to that tragedy, to take something that was so awful, that was so unjust and was so unfair, and try to prevent it from happening to others. And so at 13 years of age, I worked with classmates, and we put together an effort to give meaning to the life of a friend, someone we cared about, and tried to prevent that tragedy from happening to others. At the time, I was interested in the law. I thought maybe I'd become a lawyer someday. And so I led the effort around legislation. And that effort that started in the 8th grade back in 1989 resulted in the following year the passage of the very first bicycle helmet law for children in the United States under 16 years of age. I'll always remember the moment holding Mrs. Kelly's hand when the vote happened. It was close. It was a 3-2 vote. Certainly wasn't a guaranteed outcome. And from that moment on, in taking something that was so awful and giving it meaning so that it didn't happen in vain, I felt that someone like me, no matter how rich or poor, young or old, could make a difference in the world. And that optimism, that vision, continued throughout my high school years, where I was involved in a lot of different community service causes, volunteered a lot in the community, had a chance to see that I could make a difference. And I've carried that throughout my life. As a parent, as a volunteer in the community, as a youth coach, and even as an entrepreneur, to be able to say, I can create businesses or organizations that will have a really positive impact in people's lives. Most recently, I was really motivated to address something that personally hit home in my family and in my family's life, and was having a really large impact on society. I knew that throughout my career, as I worked in using internet technologies in the pharmaceutical realm to figure out how doctors would diagnose, how they would ultimately choose a treatment, how they would dose it or use it, how insurance companies would pay for it, that there was an ability to use information to improve those decisions. You know, healthcare is one of those unique animals that it's one of the few industries that you don't get what you pay for. If we all went to lunch and had ordered a meal because we were hungry, if we didn't get our food, we wouldn't pay. But in healthcare, no matter what a doctor does, whether it works or doesn't work, or whatever a hospital does, everyone gets reimbursed because it's a fee-for-service model. So there's no financial incentive to cure or heal people. It's just the morals of the people who are involved, and we hope that they honestly want to help others. But there's no financial incentive to do so. In fact, the system makes more money as people are sick rather than being healthy. And so there's a real opportunity to be able to improve the way decisions are being made. The largest cost in the healthcare system in the United States is failure, because failure is paid for. Very few things work. And so all of that money that's spent on failure is the biggest cost. And there's this field that's emerged called personalized medicine or precision medicine, which is basically the idea if we can give clinicians, doctors, nurses, nurse practitioners, etc., the information that they need, so when they're making a decision around diagnosis, when they're making a decision around treatment, that they'll choose the best treatment, the best diagnosis for a patient, so you get a better outcome. And this has started to be done in cancer. I had the opportunity with a company based down in San Diego to do some of these things in gastroenterology for people that have Crohn's disease or ulcerative colitis. And in my particular family, there are people that I love and care about deeply that really have struggled with pain medications. I remember early in my marriage with my wife, when she was giving birth to our first child, Nicholas, they gave her a bunch of different pain medications during the labor, and none of them worked. And then a few years later, she had this really awful sinus infection and joint pain in her jaw. And again, we were at the hospital and they were giving her pain medications, none of which were working. And I felt helpless as a husband. I felt that there was nothing I could do. My wife was like, just shoot me in the head. It was so excruciating, the pain. And it kind of harkened back to the feelings that I had when I was there on the side of the road as Chris was on the side of the road with his mangled bike, and there was nothing that I could do at that moment to help Chris. And I was there looking at my wife, holding her in the hospital, and there was nothing I could do. And so I felt, gosh, there had to be a way that I could use the things that I learned and the people that I knew to somehow address this issue. And as I learned more about the challenges that exist in addressing pain in the United States, I realized that there was a huge mess that exists. The National Academies of Science, Engineering, and Medicine recently came out and put out a report talking about how there are these dual public health crises that exist in the United States today, both of chronic pain and the opioid abuse epidemic, and they're interrelated with each other. Over the past 15 to 20 years, pain has become the nation's most prevalent and most expensive health condition, larger than cancer, diabetes, and heart disease combined. It costs more, it affects more people, yet there is a paucity or a lack of research, of information that exists around it. I mean, you think of the sophisticated ways that we understand heart disease with blood tests and genetics and mechanical devices, or cancer for that matter. Yet in pain, it's science by emoji. We look at smiley faces to frowny faces, or we ask people on a scale of 0 to 10 to rate their pain. It's the most subjective thing on the planet. My wife always jokes with me that she has a much higher pain tolerance than me, so her 4 would be my 8. And so that level of subjectivity is how we currently classify the nation's most expensive and most prevalent health condition. Well, why is that? It's because there's a lack of research around it, and that's structurally designed by virtue of the way the government is set up. There is no NIH Institute for pain. So thus, there are very few pain academic centers to get the money for that research. And so the normal pipeline that's structured for research around diseases, around diabetes, around heart disease, around cancer, doesn't exist for pain. And that has a lot to do with the societal stigma around pain. When someone has cancer, we say they're a victim of cancer. We feel sympathy for them. There's all these nonprofits and marches and walks and pink ribbons to deal with people who are victims of cancer. But if you speak with a patient who's in chronic pain, it's affecting every aspect of their life, their personal relationships, their job, their kids, etc. And they're almost suicidal. That they don't want to go on any longer. Yet there's no pipeline of research, there's no pipeline of effort to really address this. And when you think of it, the only way we classify it is with basically emojis of smiley faces and frowny faces. It makes most people laugh, but it's not a laughing matter, and especially not for the people that are dealing with this. And so after years of working with digital health technologies, from mobile devices and from the internet and from various different things to influence the way doctors would diagnose and treat patients for various different diseases, I knew that I wanted to tackle pain. It was something that I knew that I could help my wife, and I could likely help my kids and help other loved ones. And not only would it have a personal impact at the micro level, but if we could deliver on the promise of precision medicine, so that we could figure out what was wrong with the patient and make sure they're getting the right treatment for them, and do that for the nation's largest and most expensive health condition, for whatever the particular treatment may be, but whatever is best for them, then I knew that we could have a material impact on the entire society, on the entire US healthcare system, that was far larger than even anything that was being done in cancer. And so with that level of motivation, both at kind of my own personal level, as well as thinking of it in the global picture of things, I started a company working with some of the leading researchers in the world that deal with pain, that deal with genetics of pain, to be able to develop a company that would give doctors information so that they can make better decisions around how people feel pain, and ultimately which medications would work best for them. Because of that science by emoji and that lack of scientific rigor, as more and more people have had pain, as the population has aged, as baby boomers have moved from the working people that they were into the retired population on Medicare, we've seen this massive explosion in patients with chronic pain. Yet throughout that entire period of time, the medications and the treatments we use are basically based on a 2,000-year-old compound, based on opioids and morphine. And a doctor may just prescribe these medications, and we'll see you in 30 days and see if it works out. The challenge with that is, as more people have had pain, there's been more prescriptions. And just the natural byproduct of having a greater prevalence or exposure to those chemicals has created both the positive and the negative aspects of that exposure. The negative aspects of that exposure is all of the side effects that are associated with those medications. And so we now have an opioid overdose crisis in the United States, where patients, as they're being exposed to these medications, some of them become addicted. Some of them develop a tolerance very quickly. It makes them feel good. They start craving more. Generally, if you're in chronic pain, which means you've been in pain for more than 90 days, you're depressed, you're not sleeping well, all of those additional comorbidities are happening, and you're looking for answers. And as these patients go from one doctor to another doctor to another doctor looking for answers, and they deal with failure and failure and failure, what ultimately happens? We blame the patient. We say the patient's doctor shopping. And then the doctor fails miserably because they don't know what's right for the patient. They don't have that answer. And so then they get blamed because when the patients have the negative side effects, they figure somehow the doctor should have a crystal ball to know what works best for the patient. And so in the technology that was created by this company, we won tons of awards for the research we did. We did more research than anybody else, and we funded it all of ourselves, not $1 of university or tax dollars to do it. We just reinvested our profits to be able to do it. We won tons of awards for that research. We had over 100 posters presented at major medical meetings. We won awards from the American Society of Interventional Pain Physicians, the American Academy of Neurology, the American Society of Regional Anesthesia, recognizing the quality of this research because no one had ever looked at it before. Again, because there wasn't the government institute to fund it, so there wasn't the educational infrastructure within the university academic center, so there was no pathway for that money to happen. And so we invested those research dollars to be able to figure things out, and now with over 10 peer-reviewed publications in the literature just from the research funded by the company, on top of the hundreds and hundreds of scientific journal publications from the researchers that we were affiliated with, we were able to bring a technology to the market that made a meaningful impact in people's lives. And so that was something really special to be a part of. So there's basically kind of two sides to how people classify medicine. There's the homeopathic or the natural medicine, and then there's allopathic medicine, which is what we refer to as traditional medicine. But traditional medicine, if you think traditional Chinese medicine, is really much older than what we do with modern medicine. And there are a lot of different substances that are out there that, based on a lot of the same scientific principles around precision medicine, that we can better understand. For example, there's a whole class of chemotherapies that are called anti-folate chemotherapies, because folate, which is derived from vitamin B9, folic acid, is a substance within the body that affects cell replication. And so as cancer cells are reproducing, if you strip the folate out of the body, then you strip the body's ability to replicate cells. And I've got a published paper on this. And there are a lot of studies that have been done on these medications, and you can imagine when you try to stop the cells from replicating with cancer, you also stop all the healthy cells from replicating. So what happens? Hair loss, brittle nails, thinning skin, etc. So there's always a double-edged sword to a lot of the prescription medications that are out there by virtue of their mechanism of action. Well, there are a lot of natural substances that are designed in parallel or similar to these synthetic substances that pharmaceutical companies will derive. And a lot of them can be used very effectively in pain, in psychiatric treatments, in addiction medicine. And some of the clinicians that we worked with that were interested in new ways of approaching precision medicine were also looking at natural substances. There are people that are obviously using medical marijuana very, very effectively for chronic pain and other conditions. A particular substance that I'm somewhat familiar with, but certainly not an expert by any stretch of the imagination, is a substance that's commonly referred to, or a plant that's commonly referred to as kratom. Kratom, in many ways, when you look at the chemical compound, do you want me to wait till that's over, that train? Okay. Kratom in many ways resembles as a chemical compound some of the properties that exist with naturally occurring opioids and some of the other centrally acting herbs that have an influence on brain chemistry, the way the brain perceives pain, and other matters. And so I'm aware of certain clinicians and certain patients that have successfully used kratom to be able to address their chronic pain. But the inherent challenge, obviously, with any of these natural substances is really knowing the right source, the right quality, and unfortunately there's a lack of structure to appropriately address that. And so, you look at certain substances that are natural like kratom, if we can find ways through the appropriate level of research to be able to identify the right sources so that it's manufactured appropriately and made available to people, we know who it would work best for and who maybe should stay away from it, at what doses or levels or ways of consuming it. It's obviously very, very promising. We're seeing a lot of that happen with medical marijuana. There are people that use various different amino acids because amino acids are precursors to neurotransmitters in the brain. The body naturally takes it from foods. And so there are probably a lot of natural properties if we can just figure out a way and a vehicle to do the appropriate level of research to be able to understand how kratom can work best for certain patients that would be most likely to respond to the plant, then it could be very, very promising for people. Oftentimes people will rush to judgment and they'll say, oh, because there were a few people that had a negative reaction to it, then it must all be bad for everybody. Well, we wouldn't do that if we were generalizing people, so why do we do that when we generalize plant-based substances? It's illogical. You have a bad experience with a particular group of people. If you were to generalize that entire group of people, we'd call that discrimination, racism, something bad that society wouldn't respect or welcome. We need to take the same approach with substances, with plants, and there for certain people it has a really meaningful impact that you can't challenge because it's real. And I think kratom is one of those things that we need to take a measured, sober approach to and say there's obviously value there for many patients, and we just need to figure out who those patients are, how that kratom should be made available, in what forms, and ensure that the people that need it are able to get it, just as we would with any other type of plant-based or food-based substance. Pain is one of those conditions that everybody can relate to. If we were sitting here amongst a room of people and we asked, how many of you have had cancer? Maybe a couple hands would go up. Or how many of you have had diabetes or heart disease? A few other hands would go up. But if we asked, how many of you have experienced pain? Every hand in the room would shoot up. It's a part of our human existence. There's no way to avoid it. At some point in time in your life, every single person will feel pain. And so our ability to be able to understand it and treat it appropriately is something that every human's going to experience, every doctor is going to treat, every health insurance company is going to pay for. The government's never going to avoid not paying for it. And so it's something that's so ubiquitous to what it means to be human that it's really important for us to make sure that we've understood it and figured it out, because it's not something that just affects a subsegment of our society or our community. And so when you think of the opioid abuse epidemic is merely just an outcome of doctors trying to do their best by prescribing medications to people that they think are going to work, that the FDA has told them are indicated for these things. But unfortunately, there's information that's out there that's not getting to the masses. For example, how we understand pain. We know, based on published literature, it's listed on the NIH's website, that there are genetic factors that play a role in how people perceive pain. We all know it. Everybody jokes about it. You know some people that have a high threshold for pain or a low threshold for pain, but there's no science around assessing that. We know that there's certain medications that work for certain people and not for others, yet we just willy-nilly prescribe by guessing with trial and error. We know there are certain people, a small segment of the population, who will become addicted to these opioid pain medications. Yet it seems like the government either suggests that let's make it available to everybody and deal with the addiction, or we restrict it from everybody and deny patients the life-saving pain relief that they need. And so, but there is information that isn't being spread out there. For example, the American Society of Addiction Medicine, the leading medical society of addictionologists, says in their definition of addiction that about half of addiction or substance abuse is due to genetic factors. About half. You're never going to develop a genetic test that is going to predict it because it's only about half. And with technologies that I've been a researcher on and helped develop, and there's now peer-reviewed studies to support, by taking genetic information and non-genetic information, you can identify who those patients are with up to 90% accuracy. Yet doctors are out there prescribing these medications, patients are taking them, not taking into consideration what the American Society of Addiction Medicine says is 50% of the cause. Now I've got a 16-year-old son who's a junior and a 14-year-old daughter in high school and a 6th grader who's 11. If any of my 3 kids said that they were going to study for an exam, but they were going to ignore 50% of the material, I would tell them they have a pretty good chance of failing. And I don't need a clinical study to prove that. Yet, the exam that these doctors are taking every day, the exam that these patients are engaging in every day at the doctor's office, they are not studying 50% of the material. That's not what I'm saying. That's what the American Society of Addiction Medicine has said. So if you're taking an exam, whether it's an academic exam at school or it's a physical exam or medical exam at the doctor's office, and you're ignoring 50% of the material, I think well-reasoned people can assume that you're going to fail that exam. And it's that failure in those exams that's happening thousands and thousands of times a day across this country that's contributing to the opioid abuse epidemic. So let's do something about it. Yes, I know that there are people in industry that may not want to change things. And maybe there's people in academia who don't want to change things because they make money off the research. But at the end of the day, well-meaning, well-intentioned people can realize that the data exists and that we can analyze it. And there's technology to be able to do it, to figure out, does someone need a pharmaceutical, or maybe they need an herbal supplement, or maybe they need a medical device, or maybe they need to lose weight, or maybe they need to do X, Y, and Z. It needs to be individualized. And I think there's a true opportunity to do that, to ensure that the right patient is getting the right treatment so that we can address what all the experts say is a dual public health crisis in this country of chronic pain and of the opioid abuse epidemic that's killing more people now than automobile accidents. It's just incredibly scary what's happening. And I think the people need to understand that the information is there, and it's available at their fingertips, and they just need to look into it, and there need to be well-meaning people to make it available to those that are suffering from chronic pain or have loved ones that are suffering from chronic pain so that they can do something about it. If anything that I've said today is worth has value to you, that you think you can make a difference with it, I encourage you to look into it, to research it, to find out for yourself. Don't believe the prevailing norms and what people assume is right and wrong. You need to unpack it. You need to look into it further and empower yourself and empower your loved ones to find out that information so that you can do something about it and make a difference. Because at the end of the day, each of us know that knowledge is power. And by getting that knowledge, you are empowered.